Hi, my name is Mary Lou Stillwell, and I am going to give a very brief, very basic, and by no means exhaustive review of the mechanics of the hip in general and the surgical procedure called the Varus Femoral Derotation Osteotomy, or VDRO, and discuss the physical therapy considerations for this procedure. In the brief amount of time allowed for this presentation, I will try to hit the highlights of the VDRO and bring to light a few of the evaluation and treatment options for children who have this procedure done, but I'm going to focus on the acute care setting, realizing that, again, this is by no means comprehensive, as my discussion in this arena will not address outpatient or home care settings. Okay, so why do we do a femoral varus derotation osteotomy? The purpose is to reset or improve alignment of the femoral head in the acetabulum, and there are four general physical reasons for hip subluxation. The first being with vertical hip sockets, the head of the femur basically glances off the acetabular shelf into subluxation or partial dislocation, or sometimes it goes right into full dislocation. The second one is when the hip socket is too shallow. The acetabular shelf does not form around the head of the femur and does not allow the stable hip joint to develop. Thirdly, if the upper part of the femur does not angle in towards the pelvis, the force vectors during weight bearing are too vertical and subluxation can occur. And then lastly, when there are muscle imbalances, one set of muscles exerts too much influence or force on the hip, and typically this is due to spasticity, and it overpowers the stable equilibrium of the hip. Usually what that means is that the adductors, flexors, and internal rotators have too much tone and basically pull the femoral head out of the acetabulum. Many times these particular locations or dislocations are posterior and superior. Some of the common diagnoses that you will see resulting in a femoral VDRO would be what's called DDH, or developmental dysplasia of the hip. It is a congenital subluxation or dislocation of the hips, often seen in breech births, and it can be unilateral or bilateral. CP, cerebral palsy. This procedure is often done with non-ambulatory children who have significant tone issues. You will often see this with femoral anteversion, otherwise known as in-towing, that interferes with activities of daily living or general mobility and safety. Sometimes it's done for cosmetic reasons. Avascular necrosis of the femoral head, or AVN, which can lead to either leg calf perthes or complications of manual correcting and casting. And in this situation, the blood supply to the femoral head is compromised in some way. Either the blood vessels themselves get kinked when the ball of the femur is manipulated into the socket during attempts at reduction, or the vessels are disrupted in some way. Either way, this can lead to collapse and flattening of the femoral ball, especially for children in elementary school years. This sets in motion a series of events leading to further limitation of activity, usually due to pain, and if uncorrected can lead to arthritis and possible joint fusion. The issue with infants is that although the head of the femur stays round, with them the temporary blood loss can actually damage the growth plate of the proximal femur, which can then lead to leg length problems on one or both sides. So if any of the above happen, this can lead to with subluxation or dislocation with degenerative joint disease. It's either a chicken or the egg thing, where the disease can be the cause of the hip issue or the result of the hip misalignment and poor mechanics. This is often a precursor to arthritis and to potentially fused joints. With femoral acetabular impingement, it is a painful and aggravating condition where the hip labrum is often caught and pinched in an out-of-aligned hip. Pain is a huge indicator of subluxation and is often a primary reason for this procedure. With leg length discrepancy, there is often a manifestation of the hip out of alignment and is one of the first signs that something is amiss structurally. Very frequently, this is seen in non-ambulatory population with pelvic obliquity and can sometimes lead to scoliosis over time. Subluxation will interfere with ADLs. Yes, this speaks for itself, but an unstable hip reduces a person's ability to perform self-care, usually due to pain and losses of range of motion or losses of strength due to immobility. It interferes with ambulation and directly affects fitness levels, cardiopulmonary health, and can impact hygiene, especially for the non-ambulatory population. The gross motor function classification system has been cited in the literature as being helpful in determining which hips will go out to full-blown dislocation. Typically, kids who are at levels 4 and 5 especially seem to have higher incidences of all-out dislocation. And the bottom line is that dislocations are very much a quality of life issue, and this procedure, the VDRO, can help ameliorate it. Okay, so the indications for the VDRO procedure, you have basically it's done when all else fails. The usual suspects of therapeutic agents and orthopedic interventions are not enough or do not adequately stop the progression of the hip coming out of place. As part of the evaluation, orthopedists will use what's called the Reamer's Index, or percent uncoverage of the femoral head, and this is used as an objective means to assess how badly subluxed the hip actually is. A hip can be considered at risk, it can be considered subluxed, dislocated, and windswept. Each of these categories has its own Reamer's Index, and the type of surgery is fairly straightforward. Interestingly, the combinations of orthopedic and soft tissue releases are done nowadays, as they both in combination seem to provide a better outcome and lessen the need to have these surgeries repeated in the future. The bottom line for this then is, depending on the population, the VDRO is the last stop before hip replacement. Okay, so now we're set up for the battle of the osteotomies. By changing the position of the bones through surgery, the surgeon will try to shift the brunt of the patient's weight or the weight-bearing surface from the damaged joint surfaces to healthier areas. And this can be done one of two ways for the VDRO. For ambulatory kids who just need the internal rotation component fixed, the femur is simply transected and reset into more external rotation. The femoral head and neck is pretty much left intact so as not to disturb the hip capsule or muscle origins. This usually is accompanied by a plate or other hardware on the femur itself, sometimes even an intramedullary nail. The other way is to realign the femoral neck to a different angle to provide a better orientation of the femoral head in the acetabulum, again often accompanied by lots of drilling and hardware. With a Dega osteotomy, it is often done along with a VDRO to fabricate or improve the acetabular shelf. This kind of gets both end of the hip joint issue by making the pelvis fit the femoral head, and removing this is a potential problem in the future. Often especially done with non-weight-bearing children who don't have the opportunity for weight-bearing experiences that will help to shape the acetabulum through active forces. Okay, these next couple of slides are going to show the actual varus derotation osteotomy itself. This particular perspective gives a lateral view of the procedure, just where the femoral work has been done on it. This slide shows the transection of the femur, the rotation of the shaft, and the plating on the lateral femur. Often this procedure may include a shortening of the femur if there are leg length differences that need to be accommodated. This slide shows how they actually do the wedging of the femur to increase the angulation of the femoral head into the direction of the acetabulum. The first cut of the femur is sort of oblique. The second cut is more horizontal, and when you combine those two, you get an actual shortening or an internal angulation of the femoral head. This slide will show the Dega osteotomy. It shows the wedge on the lateral part of the ilium, where it's just above the femoral head and the acetabulum. is done to change the shape of the orientation of the acetabulum to the femur. A wedge of bone is usually taken from the iliac crest area and placed in that cut section that's just above the acetabulum, and what that does is it effectively pushes down the top of the acetabulum and makes a more stable and bigger shelf for the head of the femur on which to rest. Okay, now we're going to start to get into the nuts and bolts of things with the orthopedic aftermath. Two types of casts are usually used. I will address the Petrie cast the first. It is usually often very widely abducted. As you can see, the knees are extended. The ankles may or may not be included. There is usually a spreader bar. With the Petrie, the cast only goes thigh high. The weight-bearing status is usually at the doctor's discretion. Typically, it's non-weight bearing. These children are usually in this cast for about 6 to 8 weeks. The spreader bar again is done to maintain the abduction, and it's important to educate the caregivers that it is ideal to not lift the child by the bar if at all possible, but when lifting or carrying to support underneath the buttocks. The benefit of this type of cast is that because it is thigh high, it allows relatively free hip flexion, which can make a huge difference in positioning in seating devices and in car seats especially. Again, weight-bearing status is typically non-weight bearing, although I have seen some activity levels written for weight bearing as tolerated. Okay, the second type of cast is the spica cast. This one comes above the hips and includes the waist, and this directly impacts positioning because it locks the hips into whatever position or place they are casted. Now, at our facility, the orthopedists have done a much better job of casting these kids with enough hip and knee flexion to allow some type of upright position, in which many times it will allow the kids either to be in their own car seat or in an adapted car seat and not have to be lying down in the car. Usually the longer side of the cast is the one that actually has the hip that has been surgerized, so to speak. Again, typically the kids are in the cast for 6 to 12 weeks. This is time dependent though on the child. The faster the healing, obviously, the quicker they will be out. Usually it is unilateral, sometimes bilateral. There again is a spreader bar. With both the Petrie and the spica cast, children will often have that combined soft tissue procedure. Usually hamstrings, adductors, your heel cords get lengthened. If the heel cords are done, the cast will include the ankles, and these are set in as near neutral dorsiflexion as possible. Now, hardware is sometimes removed after a full recovery, which can often take up to a year, and especially if there are issues with screws being intact or loosening. Sometimes the plates need to be replaced if the kids are particularly hard on them once they get out of the cast. Plates have sometimes been known to fail or crack, and they will need to get replaced. At least here at our hospital, patients are not typically fitted with abduction bracing or other bracing once the cast is removed, although some articles I have read seem to suggest that post-cast removal bracing is done to slowly allow more movement, but to still monitor and maintain the stability of the hip. And lastly, for kiddos who are having the VDRO done just for in-towing or femoral anteversion, no casting is usually needed, at least not at our facility. Weight-bearing status is at the discretion of the orthopedist, but because they often have some type of metal hardware or an intramedullary nail, they can often be weight-bearing as tolerated. So your crutch training will continue just as typical. And again, as with most bone healing, 6 to 8 weeks is a ballpark figure for crutch use, but that can change if healing progresses more quickly. Okay, so what's a physical therapist to do? As part of our eval, it boils down to whether the child is ambulatory or not, because your interventions and goals will be different, but I more or less will list out the items pretty much as I ask of any patient or caregiver during an evaluation for this procedure, and not all of these are generally in the order in which I ask them. But for range of motion, I look at what range is available to them, generally speaking, that may impact on their mobility or a caregiver's ability to move the patient, especially true of the more involved or casted children. For ambulatory patients, I assess range of motion as I would do any patient, and that's to their tolerance. Strength, I usually look at the upper arms for the non-ambulatory children. Should they be able to assist with transfers? For ambulatory folks, the strength assessment is focused on being able to use assistive devices. With sensation, this is especially important for casted kids to make sure the casts are not too tight, and particularly if the children are nonverbal. Some of the casted kids usually get an epidural catheter with pain meds pumped directly in the spinal canal. This can affect their post-op pain, so it's important to know what their sensation level is. For ambulatory children, sensation is tested as usual to make sure the light touch is intact and some neural involvement hasn't happened during surgery or if swelling gets too bad. Pain is a big issue with these kids. With many of these more involved and casted kids, they can have muscle spasms which are really painful. Sometimes these are worse than the surgery itself due to their unpredictable nature. I need to know what pain meds they're on and what the schedule is so I can try to time my evaluations and interventions to optimize pain relief. I need to know if these meds will knock out the ambulatory kids or make them too loopy for safe ambulation. With bed mobility, several questions. How much can the patient help moving around in the bed to relieve pain, to optimize skin integrity, and to assist with hygiene or with dressing? Are they totally independent? Are they totally dependent? Does the caregiver have to help at home if the patient is a total lift? For home safety and accessibility, lots and lots of questions. How is the child going to enter the house? How wide are the doors? Is it a one-story home, a two-story home? Where are the kids sleeping? Where are they spending most of their day? How long is the house? What is the distance from their bed to the bathroom? This is especially important for ambulatory kids. Do they get up in the middle of the night to use the bathroom? Is there adequate lighting available? How lightly does the caregiver sleep in case the kid needs help? How many stairs to get into the house? Do they have a safety or an emergency exit plan? What kind of flooring do they have? Is it carpet? Is it hardwood? Is it tile? Will they be able to take showers? How high or low is the toilet seat? Are there grab bars in the shower? Are there younger siblings that might get caught underfoot? Are there pets in the house that might jump on them? How do they plan on getting the patient from point A to point B if they are not ambulatory? Questions such as these. With home and school safety, again, more questions. What are the children going to be doing about going back to school anytime soon? Are they going to be homeschooled? If they are going to school, how will they get there? By bus or will the family drive them? School accessibility issues. Is there an elevator in the school if the school is a two-story one? Does the school personnel know about this surgery and have they made accommodations for leaving class early? Does the child carry a book bag or a lunch tray? Are they involved in extracurricular activities? Can they get to the bathroom okay? Some kids are actually placed on homebound instruction. They're usually out of school for 6 to 8 weeks. Sometimes PTs will go to the home, often not until the kids are out of the cast. Medications. This goes along with pain meds in general. What other medications are they on, either as a result of the surgery or just on a regular basis? And will this affect their arousal level, their pain level, and their balance? Will they be safe? For weight-bearing status, it's more important for ambulatory kids, but again, this depends on the physician as to whether or not they can put any weight through their legs. Now, with DME needs and wheelchair modifications, what equipment are the kids and the caregivers going to need to be safe and mobile in the home? Just crutches, a rolling walker? Will they need a rental wheelchair for home or school use? Especially if they're going to participate in community outings. Many times the docs won't want them to use a wheelchair if the kid's ambulatory, but I'm a safety girl and I would prefer a wheelchair be available to them to prevent fatigue and circumvent injury. Will they need a bedside commode to make toileting easier and safer? And this is especially for ambulatory kids. If the docs allow it, will they be able to take showers? So will they need a shower chair? Are there safety mats in the tub? Do they need a handheld shower diverter if they're going to be using the shower chair? Does the family have a ramp to get the wheelchair in and out of the house? For more involved children, does their current wheelchair need any modifications, or will they need a rental wheelchair to accommodate the width of the spreader bar? Does the wheelchair need to be reclining to allow some rest time and slow accommodation of the child to an upright position to prevent precipitous stretching of the just released soft tissue? Now, with ADLs, what will the child be able to do from an orthopedic approval position? What kind of activity are they allowed to participate in? And what do I, as a PT, need to do to assist the patient or the family with preparation for this while they're still in the hospital and before they get home? If they're going to need to be able to do something, I want them to practice it in the hospital where I can keep an eye on them and I can know that they're safe and everybody's hunky-dory before I let them go out the door. As far as transportation needs, and this is including car seats, how is the child getting home? If they're ambulatory, kids can usually sit in the car as they typically do, and as long as it's in compliance with their state laws about where a kid sit. In Georgia, kids cannot sit in the front seat until they're 13. They also must be in some type of booster seat unless they are 4 foot 9 inches tall. If they are casted, can they fit in their own car seat, or do they need some alternative seating arrangement? There is a device called an Easy-On vest that can be used and have children be supine. Do they need a different specialized car seat like a hippo that will accommodate a spica cast? If they are non-ambulatory and older, will they need a stretcher van to go home? If the kids cannot lay across the back seat of the car safely without whacking their head or feet against the side of the doors, they're probably going to need a stretcher van. Many rental wheelchairs are not crash tested, and if the parents are taking public transportation, they really can't use these rental wheelchairs. Part of the evaluation is to assist the family with identifying needs such as these and consulting appropriate disciplines like social workers to arrange for transportation. So as far as physical therapy intervention, education is the key word for patient and caregiver. Typically for bed mobility, I'm showing the family how to move the child in bed, especially if they are non-ambulatory, so that they can change pressure distribution on the skin to elevate the legs and optimize position of the ankles to prevent foot drop. For ambulatory kids, your typical mobility training, supine to sitting, rolling side to side, those sorts of things. With body mechanics, we may need to use a draw sheet to assist with bed mobility. For weight bearing, a wide base of support for caregivers, you want to use the legs, not the back. No twisting, making sure they breathe and exhale with effort. The typical body mechanic stuff. With transfers, are they going to be assisted or dependent transfers? For ambulatory kids, it's your typical transfer training. Scoot to the edge of the bed, nose over toes, blow out as they rise or sit. Having help from an adult to move to the involved leg is needed. For involved kids, you educate about a one-person or a two-person dependent lift and transfer. Sometimes using just a lateral slide from the bed to the bedside wheelchair, again either with a draw sheet for better pressure distribution and support, or under the axilla and under the proximal legs. With positioning, the elevated legs are on pillows to assist with edema. You also want them to try to be as upright as able in the bed over the course of time to prevent pulmonary issues. You want the ankles in as near neutral dorsiflexion as possible if the ankles are not casted. And for ambulatory kids, you need to keep the involved leg as neutral as possible so there's no flopping out in an external rotation. Education is given to caregivers for optimal diapering changes and for positioning. With the ambulation with an appropriate assistive device, you choose the assistive device for the child based on the amount of help needed. Most of the ambulatory kids use only crutches, but depending on their age, level of arousal, pain, and cognition, sometimes I will choose a rolling walker first until they get used to being up on their leg and can hold on well with their hands, and then switch to crutches. I often find that 4 legs of a walker is better to get the safety issues and the fear issues out before I switch to crutches. 4 legs are better than 2. There's too many moving parts involved for crutches on some of these kids. I teach ambulation mostly on level surfaces, which in the hospital is linoleum and on stairs. If they have to use them in the home, I will teach stair mobility. I include the caregivers right from the get-go because they're going to be doing this at home, and I basically try to work myself out of a job so the parents and caregivers are included as much as possible, as is safe, and I want to make sure that they can do this at home before they do it. I want to make sure they do it here at the hospital before they do it at home. I don't want any surprises. I don't want them to get home and figure out that they can't do something. The other thing I try to do is to replicate the home environment as much as possible so that there is a good learning from the hospital to the home environment with therapeutic exercise. This is mostly reserved for the ambulatory kids, and it involves your typical post-op items such as ankle pumps, quad glute sets, heel slides, seated knee extensions, gentle hip abduction. That is only if the surgery was done in the femoral shaft and not if it involved the greater trochanter at all. I look at pulmonary issues, and this usually entails promoting diaphragmatic breathing for cognitively intact kids. For other kids, I use things like bubbles, pinwheels, whistles, blow bubbles in with straws through milk, anything that gets blowing so they can mobilize their secretions. Again, with ambulatory kids, walking is tolerated as probably their best exercise. Other options could be using a Wii, passing a ball very fast back and forth from one person to another, seated shadow boxing, anything that's going to get their arms up and get their heart pumping. Again, that lends itself to the fitness challenge that we have with kids who are less than ideally mobile. With pain management, this often includes icing for pain relief in the groin area. The nurses and the docs do a pretty good job of making sure pharmaceuticals are on board. Lastly, with precautions, this would entail informing caregivers of what not to do, especially for ambulatory kids. The typical no high-impact sports, follow all the doctor's recommendations on when to increase activity, keep movement in as pain-free a range as possible. You'd want to avoid immersion in water to prevent wound dehiscence or infections, until this is okayed by the doc. This is again a brief wrap-up of therapy interventions. The last slide is going to have references from which I culled this information, and of course a lot of this is just based on what I do day in and day out. But I appreciate your time and attention. I hope this was educational and helpful to you, and I want to thank you again.